Hi, I'm Christina Kabza, and welcome to Homeless But Not Healthless, where I will be discussing health disparities in the homeless population. There is a large population of people living without homes in the world. According to Gabriel Ralek, if the world were made of 100 people, 23 of those people would not have shelter. Furthermore, the population of those struggling with homelessness in America, with numbers reported over 500,000 in January 2018, is very high. There are many factors contributing to this high number, including the rise in housing costs and increased number of hurricanes and traumatic events during this time. However, in the end, 88,640 individuals experienced long-term homelessness in 2018, an increase of 2.2% over 2017 levels. There's a huge disparity in the level of health care administered to the homeless population, and even greater is that of those struggling with mental health. One study reports the risk of death in the homeless population as 3 to 4 times higher than average. These rates are the worst within the age range of 18 to 54. Another study reports shorter life expectancy, high morbidity rates, and greater usage of acute hospital services. Comorbidities such as cardiovascular disease, asthma, and obesity are made worse by the high rates of severe mental illness among this population. While the homeless already have a greater risk for health issues, those with mental health are even more at risk. According to a study conducted by professors at Dartmouth Medical School, people struggling with severe mental illness are likely to die 25 years earlier than the rest of the U.S. population. With the disparities among homeless populations being so well known and acknowledged, why is this still the case? In the United States, our healthcare system follows a market justice system, wherein healthcare is provided under a system similar to the free market, called a quasi-market, that views healthcare as a good or service to be delivered based on supply and demand. Since this market justice sees the distribution of health services to those who can't purchase it as morally and ethically incorrect, the homeless population, made up of people struggling to find stable employment and housing, are unable to work or pay for the healthcare services and therefore receive healthcare at an extremely disproportionate level when compared to the sheltered population. Looking to the vulnerability framework may prove to be a helpful tool in assessing why there is such a large disparity in health among this population. The vulnerability framework is a tool that identifies ecological and individual predisposing, enabling, and need characteristics that affect health outcomes at both the individual and population level. Predisposing characteristics encompass the biological and demographic factors that predispose certain groups to poor health outcomes. Among the homeless population, predisposing characteristics include the large number of racial minorities and people struggling with mental illness. One article reports that mental illness affects up to 18.4% of this population. When focusing on those struggling with mental illness, concurrently with homelessness, the main predisposing characteristics can be broken into emotional, cognitive, and social disruption. These factors in combination usually debilitate individuals and result to a depletion of resources, such as food, money, water, shelter. Enabling characteristics are the resources available or unavailable that affect health. The homeless population has an extreme lack of accessible resources. Employment rates among the homeless population are very low. Since insurance in America is primarily tied to employment, this creates a large number of uninsured among this population. Furthermore, the lack of basic needs such as food, water, and shelter create an immediate need that often overshadows their need for other health services. Lack of transportation is another factor that affects the accessibility of healthcare resources greatly. Many live in urban areas where public transportation is available at a cost, but there's also a large population, about 27%, of homeless individuals in rural areas where public transportation is extremely minimal. The final factor in the vulnerability framework is the need characteristic. When looking at the homeless population, the large barriers and lack of resources that restrict accessibility to healthcare result in confounding factors that may skew results. Therefore, the utilization of services does not necessarily point to the actual need of the population. For example, when looking at utilization, one may find a low use in ambulatory services among homeless populations. However, this doesn't mean that the population is not in need of ambulatory care, but rather point to a trend that insured people use ambulatory services at larger rates than the uninsured. Furthermore, the homeless population may lack the resources and insurance necessary to receive primary or specialized services. The immediate need for resources such as food and shelter, and specialized care such as amputations or cardiovascular services, often overshadow the root of the cause. After much research, I found a consistent need in medication and treatment of mental health disorder. These disorders often predispose and enable this group to disproportionate health care, and the resolution of these problems will lessen the severity of other health issues. There are many factors that have resulted in the disproportionate deliverance of healthcare to the homeless population, including resources, predispositions, and the system itself. Although I didn't find much scholarly research discussing the topic, in my personal experience, I found that social attitudes toward the homeless population have greatly affected the emotional and societal well-being of this population, and should be considered when looking at the disparities in healthcare administration. One current potential solution that I found compelling was a partnership between the Jefferson Department of Family and Community Medicine and a housing first agency called Pathways to Housing, PA. Because homelessness is a multifactorial, complex issue, the solution is not simple. But this partnership is utilizing a patient-first framework for addressing the issue of this population, which will eventually address the health disparity. Many of the disparities discussed in the text come down to the systemic approach we use as a country to deliver healthcare. So what's your appraisal of the current state of our healthcare system? Evaluate how strictly we should follow our quasi-market approach to delivering healthcare. Analyze if public partnerships, such as the one discussed earlier, should be responsible for addressing incongruencies in the healthcare system, or if the government should take responsibility for these underrepresented populations. Thanks for listening, and I hope this video gave you a view of the U.S. healthcare system from someone else's perspective.